Is there any, Chris, is there anything I've said that contradicts something that you've learned or that you've applied?
No, not really. The only difference I learned was just that the annulus pulposus is typically a problem in young people because they still have them. And, facet joints tends to be a problem in older people because of arthritic changes that can happen in that joint. But that was in a,
Wait, what was that you said about young people don't have their nucleus pulposus? What?
If someone has radicular symptoms, and if there's radicular symptoms in a younger person, that think nucleus pulposus, because young people tend to have more nucleus pulposus, right? It hasn't dried up. It hasn't had that mechanism that you described earlier where it dries up.
Oh,
You know what I mean? And so
yeah,
that if they're,
yeah. Oh, absolutely.
that's the only thing I think.
We rarely deal with kids with radicular symptoms. I had radicular symptoms when I was 16 from a back injury, but it was short term, and we just don't see kids with radicular symptoms very much. But that's our clinical setting. Remember, we're chiropractors, so.
Right. I did have a question for you about regenerative medicine in this lecture. So like thinking about a knee and lower back pain. So if we have a patient with lower back pain, they have radicular symptoms, do we want to try and inject them to see if that relieves their pain? Or do we get them worked up for that radicular pain first and then do an injection?
And that is a great question. And I'm absolutely going to answer that. To answer it the way I want to answer it would require like another hour. That's like down the road.
Okay.
Because you're asking a very specific question about a very specific condition. So I'm going to give you the quick overview, but then we'll talk about why. So if you're talking about a radicular symptom, you're talking about a nerve impingement. Mm-hmm. And in order to, and it's usually from a bulging disc, is that right? You're talking, so you got a bulging disc hitting a nerve, and are we going to do an injection for that?
Right. Well, so what I'm asking more specifically is just sort of what the clinical process is and how we work that up, because you could offer to do the knee injection and see if that brings relief, and if it brings relief, then it's
what
probably
kind of injection were you talking about?
Like PRP or Prolo.
PRP injection to relieve the pressure on the disc.
Well, I was thinking more for the knee pain. Because I'm assuming we're doing mostly peripheral injections here, and so do we want to see if it provides relief? In which case, we think maybe the knee pain's not radicular, or do we work up that radicular pain before we offer them, like say the PRP or the Prolo, to see if it's the radicular symptoms that are actually causing the knee pain? Because I
got it. You're talking about using it diagnostically to determine which is the source. Okay, great question. And my answer is going to be, we better figure that out before we do any injections. So there's different ways to differentiate. Have you worked with chiropractors on these kinds of conditions before?
I've worked with chiropractors, but not on.
Okay.
Yeah.
Yeah, so the advantage we're going to have is that since we work on so many bulging discs in the low back, so I had a patient come in, actually what's more common, so I have patients who come in with knee pain caused by a pinched nerve in the low back. And the nice thing I do is I go, look, you got knee pain, and of course we x-ray the knee and we see some arthritis, and we move the knee and we find some tender spots. So now the common one is going to be, you have arthritic damage, you have pain that's coming from your ligaments in your knee, but you also have a pinched nerve in your low back. And so typically I can think of only one case where I had a patient come in, they had no low back pain at all, and they had regular knee pain. Now there's all kinds of, remember, we always go back to mechanism of injury and symptoms. He had no mechanism of injury. He did not injure his knee, but he'd been having the knee problems ever since basketball. He played basketball in college, and he started having knee problems, and he'd had people work on his knee, work on his knee, work on his knee. And that made sense because he had no low back pain. But what was interesting is when I'm running orthopedic tests, I can't find anything wrong with his knee other than point tenderness at certain ligaments. So I'm sitting there going, but when I examined his back, I found all kinds of restrictions and pain and range of motion. So just because of the fact that I do so many low backs, it was easy for me to figure out that he actually had a degenerative disc in his lower back, even though he had no symptoms. And so I even looked at him, I said, hey, you got a back problem, you just don't know it. And I'm like, and you're pinching the nerve root that goes to the knee. And so what's nice for me is before I do an injection, I'm like, we're going to do 4 or 5 adjustments. Adjustments are safe, they're fast, and they typically give good results. And so I adjusted him in his low back, and after 1 adjustment, his knee pain cleared up 80%.
Yeah.
So see, I'm doing the opposite. I'm using adjustments to rule out or determine. And like I tell people too, the other common one is I get a ton of, I got pain in my hip and low back pain. And so basically what I'm telling you, Chris, is in a situation like that, it's generally not super confusing. The only hard part is, and this is what I tell patients, I go, okay, we have a clearly arthritic hip. It's got X amount of decay in the joint. You could see it on the x-ray, or you could see it on the ultrasound, and you have localized pain. But you also have a bulging disc in your back that's creating radicular symptoms. So is it 50% of the pain is coming from the hip itself and 50% from the low back? And so we just kind of manage the expectations, but we'd like the chiropractic because it's fast and we can see changes immediately. And we just tell the patient, I think 80% of your problem is the low back and 20% is the hip. We're going to try this first. If that doesn't work, then we're going to try this. And quickly we can differentiate how big a factor both of them are. So